Assalamu alaikum. It's a new series where I will discuss about some relevant topic regarding cardiology. Okay, this is a very like monotonous discussion regarding cardiology, but it is very helpful for you guys. Okay, start with some questions. Okay, first thing you need to remember, if you find in cardiology, you will find cases of shock. Like if you find a case where there is fever, there is warm, dry skin. So cool, calm skin is one kind of shock, and warm and dry skin is one kind of shock. So probably warm and dry skin and blood pressure is low and there is high WBC count, looks like septic shock. So in septic shock, what will happen? In septic shock, cardiac output will be increased. Pulmonary capillary wedge pressure will be decreased. Systemic vascular resistance will be decreased, and central venous pressure (CVP) will be decreased also. So, in shock, whenever you find a case with shock, you need to think about these four things. And there is another thing, venous oxygen consumption, which is increased in septic shock. Again, in uh, septic shock, it is increased. Okay, suppose you find a case with SVT, supraventricular tachycardia, narrow complex QRS without P wave, narrow complex QRS without the P wave, indicates that AV nodal re-entered tachycardia, type of paroxysmal supraventricular tachycardia. The initial step is vagal maneuver. In here, in SVT, initial step is vagal maneuver. If vagal maneuver fails, then you can give adenosine. You can also give adenosine can cause bronchoconstriction. So, in a patient with asthma, you cannot give adenosine. Very, very, very high yield. You need to remember these things. Okay, so suppose you find a case where there is a premature ventricular tachycardia, PVC, premature ventricular tachycardia. It may happen in premature ventricular tachycardia. What may happen? In here, there is a rate is normal, normal exceeds regular sinus rhythm, and single premature ventricular complex. There may be single premature ventricular complex like broad QRS, polarity of the ST signal and T wave discordant, P wave discordant. So in PVC, premature ventricular target, there may be skipped beats, and in here you need to do observation and the rest. Observation and the rest is the thing you need to do in PVC, premature ventricular contraction. These things are very complex, and it can happen. Those who take more and more caffeine, alcohol, and nicotine consumption, these can trigger these premature ventricular contraction. Okay, if you find a case with if you find a case with like monomorphic VT, if you find a case with monomorphic VT, what is your diagnosis? What should you do? Look at this ECG. Mm, this is the ECG of the monomorphic VT. So, what what is the plan of doing if you find a case with monomorphic ventricular tachycardia? The first stage in the management of these arrhythmias to check the heart rhythm, hemodynamic stability, and monomorphic VT lasting more than 30 seconds indicates sustained rhythm, chest, tachycardia, hypertension, and hemodynamic instability. In here, you need to do synchronized cardioversion. In synchronized cardioversion, in hemodynamically unstable cardiac arrhythmia, such as atrial fibrillation, atrial flutter, and monomorphic VT with palpable pulse. So, and defibrillation, like unsynchronized cardioversion, is indicated in hemodynamically unstable patient with pulseless VT. These two things is very, very, very high end. You need to remember. Monomorphic VT patient is hemodynamically unstable with a pulse, presence of pulse. Do synchronous cardioversion. So synchronous cardioversion is done in atrial fibrillation, flutter, monomorphic VT with a palpable pulse. And defibrillation, unsynchronized cardioversion. It is usually done in pulseless VT, polymorphic VT, and a palpable polymorphic VT and a palpable pulse. Okay, if you find a case with gravity distension, absent radial pulse during inspiration, there may be distant heart sound, hypotension, distant heart sound. Think about the big stride, cardiac tempo, and so do pericardiocentesis. Pericardiocentesis. Okay, we know that if you find in infective endocarditis in blood culture, if you find strep galolyticus, what should you do next? You should do colonoscopy in this process. So, if you find a case with a rheumatic fever and there is a carditis, a soft early systolic murmur, the subcutaneous nodule on the elbow and the wrist. In this case, intramuscular benzathine penicillin every 4 weeks for 10 years or until 21 years, whichever is longer. Whichever is longer. And for up to okay, if there is a patient with symptoms of dyspnea, jugular distension, bilateral ankylodema, history gallop, bilateral JVD distension, bilateral ankylodema, history gallop, and a chest X-ray to enlarge cardiac shadow, prominent vascular margin, suggest of heart failure due to carditis. So heart failure can happen due to carditis, and the carditis is a feature of acute rheumatic fever. So suppose a 9-year-old boy is brought to you, progressively worsening shortness of breath for 3 years. He has had fever, malaise for the past 5 years. He had a sore throat 3 weeks ago, resolved without treatment. He appears ill. His temperature is 38. His temperature is 38. Examination shows regular organization and bilateral ankle edema. There are erythematous ring-shaped macula and patches over his trunk, ring-shaped macula and patches over his trunk that are well demarcated. Auscultation of the chest shows crackle at the lung base, and his history gallop is heard. His hemoglobin concentration is 12 and two leukocyte count is 13,600. Platelet count is 280,000. Urine analysis show no abnormality, and X-ray chest show cardiac shadow enlargement with prominent vascular marking in both lung failed. So what do you do in that case? Looks like this is a case of what? This is a case of acute rheumatic fever. And in acute rheumatic fever, you know the Jones criteria: migratory polyarteritis, or myocard, encarditis, nodule, subcutaneous nodule, erythema, marginatum, and Sydenham chorea. These are the features you may find in um, acute rheumatic fever. 12-year-old girl supposed respiratory tract infection 3 weeks ago, feeling like rheumatic fever, but can happen something else also. Few inspirator crackles are heard in around the history, all of these heard graphic. Hemoglobin is 11.6, liver at 8,900. Next of the chest show mild cardiac enlargement. Next of the chest show mild cardiac enlargement. So this 12-year-old girl came with mild chest pain on exertion for a week. She does not have a fever or rash. There is upper respiratory tract infection 3 weeks ago. So there are a feature. What are the features? This patient presents with features of pulmonary congestion, dyspnea, inspiratory crackles, and increased central venous pressure, jugular venous distension, eating, as well as cardiac enlargement of chest texture, of which congestive heart failure, the combination of chest pain, and a history of recent operations, the combination of the chest pain and the recent history of the operation with tract infection make myocarditis more likely causes congestive heart failure. So myocarditis can happen by Coxsackie B virus. Myocarditis is the most commonly caused by viral infection. Coxsackie B virus known as the 1986. Coxsackie B virus most common causes of viral myocarditis in children and adolescents. Features cardiac dysfunction may be preceded by signs of infection, symptom, blah blah blah. This is a new course of the dummy. So if you find a case with dyspnea, if you find a case with dyspnea, jugular venous distension, dyspnea, jugular venous distension, respiratory crisis, social pulmonary congestion, increased vascular marking, cardiac enlargement are consistent with decompensated heart failure in young, otherwise healthy patient with a history of recent operational fracture during chest pain. During inspiration, pericardial heart failure most likely due to myocarditis. Viral myocarditis. So myocarditis, a wide range of clinical presentation from subclinical myocarditis to the DCM, dilated cardiomyopathy with features of acute decompensated heart failure. As seen in this patient, myocarditis is the most commonly viral infection. Often affects the young child. If myocarditis is suspected an ECG, cardiac biomarker troponin, and chest X-ray should be obtained, and the chest X-ray should be obtained. ECG may show non-specific signs of myocardial damage. In patients with myocarditis, dilated cardiomyopathy, echocardiography typically shows ventricular dilation and global ventricular hyperthyroidism. So, 5 day history of dyspnea is very high. He has upper respiratory. If there is upper respiratory tract infection 2 to 3 weeks back, then now there is JVT distension, heart failure like feature. Think about viral myocarditis. Think about viral myocarditis. If uh, if one history, if a history group is streptococcus, history of sore throat 1 weeks back, and now there is joint pain and other things. Think about rheumatic fever. So you need to differentiate between viral myocarditis and rheumatic fever. In viral myocarditis, there is JVT distension, inspiratory tract also the lung fills, and there is a gallop in the heart. History gallop in heart. Okay. If you find a case with pain increases, with respiration decreases, with sitting upward and leaning forward, sitting upward, leaning forward, there will be disease segment elevation in all legs. There is high vision, looks like pericarditis. Pericarditis can lead to cardiac tamponade and under fluid are secreted into the pericardial space, and cardiac tamponade can lead to hemodynamic compromise. Therefore, treatment with pericardial synthesis should be done in pericarditis. Let's take a break of 2 to 3 minutes. I will come again. Keep, keep on. Back again. Let's go to next. So, if there is prosthetic patients with prosthetic heart valves increasing infective endocarditis, give amoxicillin 1 hour before the procedure. Amoxicillin 1 hour before the procedure. Azithromycin is a second line drug. It is used if the patient is allergic to penicillin. However, so if you find the case with a murmur, if the patient 3 months ago aortic prosthetic valve, now there is murmur, so it happens. The new onset murmur happens due to staph epidermidis, coagulase negative staph epidermidis. Form a biofilm early on the prosthetic valve, less than 12 months old, and the surgery. Infective endocarditis due to staph epidermidis have an insidious onset with a subacute disease course. Staph aureus, other leading cause of prosthetic valve infective endocarditis, typically causes acute disease with high fever and hospital symptoms. So IV nafcillin, rifampicin, and gentamicin for prosthetic valve endocarditis. For prosthetic valve endocarditis, IV nafcillin, rifampicin, and gentamicin for 2 weeks. For a patient with staph epidermidis, methicillin susceptible. If the patient is methicillin susceptible, IV nafcillin, rifampicin, and gentamicin. So, in an individual who injects drugs in combination with fever, night sweat, weakness, increased inflammatory marker, and the heart murmur, characteristics of tricuspid regurgitation such as right-sided infective endocarditis, septic pulmonary embolism is a common and severe complication of right-sided infective endocarditis caused by bacterial thromboemboli from the affected heart valve. Acute infective endocarditis staph aureus. And subacute infective endocarditis, virulence group, subacute infective endocarditis, virulence group. The virulence steps sanguinous, subacute infective endocarditis. Native heart valve, bicuspid aortic valve, because variants typically are the part of the normal flora. Variants typically are the part of the normal flora and can be introduced into blood following dental procedure. It can be introduced following dental procedure. So if there is fever, low grade fever, light night sweat, shortness of breath, in combination with systolic heart failure, yeah, splinter hemorrhage also known. Think of it subacute infective endocarditis, subacute infective endocarditis. If you find a hackett organism, hatchet or hackett organism, then you should keep third generation cephalosporin that cover against gram-negative bacteria. The treatment of transplant infective endocarditis caused by tachycardia is alternative to fourth generation cephalosporin. Alternative is fourth generation cephalosporin. Fluoroquine, fourth generation cephalosporin or fluoroquine. Like ciprofloxacin, amoxicillin, like ciprofloxacin and amoxicillin. Infective endocarditis is a must-know topic. So children with congenital heart disease increase risk of developing this condition, increase risk of strep sanguinus. Children with congenital heart disease are increased risk of infective endocarditis. Immunologic phenomena and vascular phenomena. Immunologic phenomena is glomerular nephritis manifestation in nephritic syndrome, rocks. Immunologic is rocks. Splinter hemorrhage, Janeway, JC virus, Janeway, splinter hemorrhage is uh, vascular phenomena. Vascular phenomena. So infective endocarditis, tricuspid valve, rectal circulative, no contraindication, incorrect is planning go. In patients with native heart valve, such as frequent coverage of MRIs. Acute limb ischemia, immunotrophic hyperreflexia, Babinski sign, cranial nerve deficit, facial fluid, dysarthria, and anomic aphasia. Inability to name object, anomic aphasia, inability to name object. The indicator of cerebrovascular accident, which is the while the patient has multiple risk factors for cerebrovascular accident is 10-day history of fever suggests an infectious cause established suggests an infectious cause. So septic emboli. This patient has infected endocarditis with increasing fever, genuine lesion, new murmur, hematuria, and through treat more than 3 RBC or new analysis. Complication of infected endocarditis. Ischemic stroke, and cerebral hemorrhage, cerebral myocarditis, and often by septic emboli to the brain. Up to 40% of the patient will.